Okay, so we just talked about chapter 24, adrenergic drugs. These are sympathomimetics, anticholinergics. We're going to talk about the opposite side, adrenergic blocking drugs or antiadrenergic drugs. Okay, do not get confused. Technically, these are also on the cholinergic side, right? And these are also parasympathomimetics. That means they act like the parasympathetic nervous system. So they're going to decrease heart rate, decrease blood pressure, decrease, their bronchial dilation or increased respiratory effort. They're going to increase output, like urinary output and bowel movement output. They're going to increase bodily fluids like saliva or secretions in the mouth or stomach acid, right? So these are on the opposite side. And when we talk about adrenergic or adrenergic blockers, we're specifically talking about the heart and lung effects versus the drying or wetting effects, right? That's more the cholinergic side. I apologize. I'm outside. My doggies are barking. Just bear with me. So adrenergic blockers are going to be working on that parasympathetic side. There's different types of adrenergic blockers and different examples of those as well. The first class is the alpha adrenergic blocking drugs. These are called alpha blockers. These medications work by blocking the alpha receptors of the adrenergic nerves that control our vascular system. And because they're blocking the alpha receptors, they cause vasodilation. And remember, when we make the vessel bigger, the blood pressure goes down. So when the opening of your water hose is a bigger hose, it's going to be less pressure, right? Vasodilation. So that decreases BP. Okay. An example of an alpha adrenergic blocking agent is phentolamine, which is regatine. Sorry, my cat got attacked by a starling, so I had to let her inside. Darn it. Okay. Why do we use alpha blockers? We use alpha blockers for high blood pressure, right? If people have increased blood pressure caused by a pheochromocytoma, one of those adrenal gland tumors, these medications can help reduce their blood pressure through vasodilation. And then if you just generally have hypertension before or during surgery, we might use an alpha blocker to decrease your blood pressure, right? Because we want your blood pressure to be at a reasonable place during surgery. So if we're increasing your blood pressure, we're decreasing your blood pressure because we're an alpha blocker, we're vasodilating, decreasing your blood pressure, what kind of symptoms might you have? Well, with decreased blood pressure, you might have decreased blood pressure, hypotension. Hypo means low, right? You might also have some orthostatic hypotension. So when you change positions, you have some changes. Weakness, okay, because you're not getting as much blood flow to like your brain and your muscles. Potentially a cardiac arrhythmia. And this one's a little bit counterintuitive. You actually might have some tachycardia with an alpha blocker. So be aware of that, even though that doesn't make as much sense. You would think more like bradycardia, right? Contraindications and precautions. If you're allergic, you shouldn't take it. If you have coronary artery disease, you shouldn't take an alpha blocker. And then we're careful giving alpha blockers to people with Raynaud's disease, that phenomenon where they have vasoconstriction in their peripheral body parts, people who are pregnant, women who are lactating, and to clients after having a recent MI, a myocardial infarction or heart attack, or clients who are in renal failure. Interactions, and just because they're going to be doing the opposite effect, right? So phentolamine and epinephrine. Epinephrine is going to be raising that blood pressure while phentolamine is working to decrease the blood pressure. So both medications are going to be a little bit less effective when given together because they're working against each other. Okay, the second class of adrenergic blocking drugs or anti-adrenergic drugs is beta adrenergic blocking drugs. These are our famous beta blockers, right? They work by decreasing or blocking the stimulation of beta adrenergic receptors. And what does this do? Well, it doesn't just decrease our blood pressure. These also decrease our heart rate. That's a huge teaching point and testing point for beta blockers. They decrease the heart rate and the blood pressure. And they decrease the blood pressure through some vasodilation. They also ultimately decrease your cardiac workload. That's how hard your heart has to work. The cardiac excitability, which means how your heart is firing signals of electric in order to conduct a signal that will produce a response. And they decrease oxygen consumption. These also are really great at stimulating the membrane to produce some antiarrhythmic activity. So if the client is in a tachyarrhythmia, these are a great medication for them. So we break these into two classes because there are cardiac beta blockers and then there are like ophthalmic beta blockers for people who have glaucoma. The cardiac are esmolol, propranolol, atenolol, acebutol, metoprolol, and sotalol. They have LOL on the end in general, right? Beta blockers. For the eyes, we have betaxolol and temolol, which help to reduce pressure in the eye caused by glaucoma. So knowing that, what are the uses for the medication? Well, we talked about glaucoma decreases blood pressure in the eyes. And then obviously hypertension, they're going to decrease blood pressure, right? Beta blockers decrease blood pressure. Stable angina pectoris. So this is chest pain. And stable means that it's chronic, but it doesn't seem to indicate that there's going to be any serious risk for heart attack immediately, right? Okay. Cardiac arrhythmia is one of those, like VTach or supraventricular tachycardia, because these are going to reduce the heart rate. So if you're already in a tachyarrhythmia, these are great for you. Migraine headaches, heart failure, and then for myocardial infarction patients, after they've had an MI, we put them on a beta blocker to help prevent an overloaded heart because the heart has been stressed and potentially damaged because of the myocardial infarction. So these medications will help to take some of the work off of the heart. Okay. Feel pretty good about these ones. Hopefully you do too. I'm trying to see if there's anything else that I need to talk to you about with these particular medications. I don't think so. Okay, we're going to move on. Beta blockers are more effective for African Americans than other blood pressure medication. Just an interesting fact. Everybody's body is different, but we found a propensity towards beta blockers working well for African Americans. Adverse reaction. So if we're giving you something to decrease your blood pressure, you might have some orthostatic hypotension. And we know that these beta blockers affect your heart rate and your blood pressure. Therefore, maybe some bradycardia. And then with that, your heart isn't beating as fast, your pressure isn't as high. You might have some dizziness, maybe some vertigo or headache as well. Beta blockers can increase the risk of hyperglycemia or high blood sugar. They also can cause some nausea, vomiting, diarrhea. And we have to be very careful giving beta blockers to asthmatics because in patients with asthma, they're at increased risk for bronchospasm. So that's like an asthma attack, right? Sometimes when giving beta blockers, we see heart failure signs and symptoms, things like dyspnea, weight gain, and peripheral edema. We do see that older clients are at increased risk, especially for these adverse effects. So we have to keep a close eye on them. Sometimes they'll even pass out because their heart rate is so low and their brain's not being fed enough oxygen with every pump of their heart. So they'll get really dizzy, lightheaded, and then they'll pass out and then have some injury related to that. So we have to keep a close eye on them. Contraindicated if you're allergic, please don't take it. if you have sinus bradycardia, so your heart is already beating slow, or potentially even a second or third degree heart block, which means your heart is not coordinating well in the first place, you probably don't want to take a beta blocker. And then heart failure. Although with early heart failure, sometimes you will see a beta blocker prescribed. With late heart failure, where the heart isn't even really able to pump effectively to keep you alive, we don't want to decrease its efficacy. So beta blockers would not be a good idea for these patients. Asthma, because of the increased risk of bronchospasm, same thing with emphysema. And then if you already have low blood pressure, so hypotension, this is not your medication. If you have diabetes, thyrotoxicosis, or a peptic ulcer, we want to be careful giving you these medications. Okay. Beta blockers are the best blood pressure medication for pregnant women because there's a decreased risk to the fetus. So we do love giving pregnant women beta blockers. Pregnancy is not a contraindication or precaution with beta blockers. Interactions. So we know MAOIs actually can increase your blood pressure, and SSRI antidepressants can mix with the MAOIs and with obviously our adrenergic blockers. And that's going to increase the effect of the beta blocker. Very counterintuitive. So clue into that. MAOIs typically increase blood pressure, but in this case, when combined with an adrenergic drug, specifically a beta blocker, you're going to have an increased effect of your beta blocker. So potentially some bradycardia. NSAIDs and salicylates, when we mix with those with beta blocker, the beta blocker does not work as well. So like aspirin and ibuprofen, our beta blocker is not going to be as effective. Loop diuretics, well, loop diuretics pull fluid off of the body, which decreases blood pressure. So if we mix those with a beta blocker, we have that increased risk of hypotension or low blood pressure. Clonidine. So we said sometimes we don't see the effect we anticipate. That's called a paradoxical effect. So with clonidine and beta blockers and other adrenergic blocking drugs, we do see increased risk of that paradoxical hypertensive effect, which means our blood pressure actually goes up instead of down. Cimetidine and lidocaine can increase the serum level of that beta blocker and increase the risk of beta blocker toxicity. No good, right? The third class of antiadrenergics is the alpha beta adrenergic blocking drugs. So this actually does what the alpha blockers do and what the beta blockers do. So it's a combo type drug, right? So these medications work by blocking stimulation of both the alpha and the beta receptors. And this causes some peripheral vasodilation, resulting in that decreased blood pressure and decreased heart rate that we see, and then also decreased cardiac workload. Two famous drugs in this alpha beta class are carvedilol or Coreg and labetalol. We use these medications for clients who have hypertension, so high blood pressure. That's pretty intuitive. And then also for heart failure. These are really going to decrease the cardiac workload. Adverse reactions of these medications. Most adverse effects to alpha betas are pretty mild and do not require discontinuation of the medication, especially when we're giving for something like extreme hypertension or heart failure, right? Risk versus benefit. We want that medication in your system. But they can be some troublesome side effects like fatigue, dizziness, drowsiness, the inability to go to sleep or insomnia, weakness, diarrhea, hypotension, dyspnea or difficulty breathing, chest pain, low heart rate called bradycardia, and skin rash. Remember all the adverse reactions of alpha plus all the adverse reactions of beta blockers. Contraindications and precautions. These medications are contraindicated, again, if your client is allergic or has asthma, because these can cause bronchospasm. Also, if your client is in that decompensated heart failure, that later heart failure where their heart no longer is responding and is not able to pump effectively to produce enough oxygen for in tissues, right? And then severe bradycardia. If your heart rate is super, super low, you shouldn't be taking this medication. That's bad news. Used cautiously with drug-controlled heart failure, chronic bronchitis, if your client has decreased heart or liver function, if your client has diabetes or while they're pregnant and lactating. Mixed with either tricyclic antidepressants or SSRIs, beta blockers could increase the risk of tremors. Mixed with cimetidine, increase the risk of that, or excuse me, increases the effect of the adrenergic blocker. So it's a more profound effect. So lower blood pressure, lower heart rate. With clonidine, alpha beta blockers increase the effect of the clonidine. So be prepared for some of those adverse effects of clonidine as well. And then digoxin, we're going to talk about these drugs a little bit later. There's an increased risk of digoxin toxicity. Okay, let's talk about this fourth class. Centrally and peripherally acting adrenergic drugs. And I think this is supposed to say anti-adrenergic drugs or adrenergic blocking drugs. I apologize that it does not. Something I definitely need to go in and fix. Peripherally acting decrease the release of norepinephrine. So we know norepinephrine is one of our pressors. So if we're decreasing the pressor, we're also decreasing the blood pressure. Centrally acting decrease the central nervous system, and therefore that inhibits the sympathetic nervous system, which is responsible for increasing our heart rate and blood pressure. Even though the actions of peripherally acting and centrally acting antiadrenergic drugs are different, the effects of the medications are similar. So we're going to talk about them together. There are some examples for each class. Peripherally acting, we can give prazosin for hypertension. We can give doxazocin for hypertension and benign prostatic hypertrophy or enlarged prostate in the male. We can give silodosin for benign prostatic hypertrophy, and then tamsulosin, Flomax is a big one for benign prostatic hypertrophy. And then we have our centrally acting adrenergic blockers. And this is going to be like clonidine or catapress. We use this a lot off label. So not only is it good for people who have hypertension or high blood pressure, it's also good for pain control, especially in cancer patients. It also treats some types of Tourette's, and we use it during alcohol withdrawal. And then methyl dopa is also good for hypertension. Okay, since we've already talked about the uses, we'll jump down to adverse effects. With centrally acting, we have dry mouth, drowsiness, sedation, some anorexia or loss of appetite, rash, malaise, or just a general kind of groggy, achy feeling, and then weakness. With peripherally acting, that's where we really start to see some hypotension, weakness, lightheadedness, and bradycardia, which is that decreased heart rate. Contraindications and precautions. So peripherally acting antiadrenergics are contraindicated, specifically reserpine, if your client has active peptic ulcer, ulcerative colitis, or depression. And then obviously also if they're allergic to the medication. We wouldn't use peripheral acting antiadrenergics cautiously if your client has a history of psychotic depression or psychiatric depression, right? Renal or cardiac disease, or if they're pregnant or lactating. And then for centrally acting antiadrenergics, they're contraindicated in people with active hepatic disease. Now, remember that's disease of the liver. Patients on MAOIs, those monoamine oxidase inhibitors, and patients who are allergic. And they're used cautiously in clients with a history of liver disease or renal issues, those clients who are pregnant, and those clients who are lactating. Adrenergic drugs mixed with anti-adrenergic drugs will increase that risk of hypertension because remember, pressors raise the blood pressure. Levodopa mixed with these medications can decrease the effect of the levodopa and also cause hypotension. Anesthetic effects mixed with anti-adrenergics is going to increase that anesthetic effect. Beta blockers mixed with other adrenergics can increase the risk of hypertension. We can have that paradoxical effect, right? Lithium can increase the risk of lithium toxicity, and haloperidol can increase the risk of psychotic behavior. Oh man. Let's talk about the ADPI. What do you do as a nurse? So for assessment, document their history, including the history of their symptoms. Get some baseline vital signs, including their heart rate, especially with beta blockers. That's a huge test question for ATI and NCLEX. Be checking their heart rate. Determine their pulse rhythm. Is it normal? Is it regular, right? Document their pain assessment if they're having some chest pain called angina. Look at their labs, their EKG, their echo, etc., and assess for signs of heart failure, signs and symptoms. So whether it's right-sided or left-sided, we might have some crackles in the lungs or some collection of fluid in the extremities, right? Depending on what type. On an ongoing basis, you need to be checking vital signs and doing a pain assessment. You need to watch for adverse effects. You also need to be repeating those periodic labs, checking those out, and then potentially even some repeat EKGs, depending on the doctor's orders. Diagnosis for these type of medications, maybe some impaired comfort due to dry mouth, ineffective tissue perfusion because of the hypotension, and then risk for injury, especially because of dizziness and hypotensive syncope, right? Passing out. Therapeutic response is based on the indication. So the planning, our goal is that that the drug does what we want it to do, right? That's what that means. That we prevent or manage any adverse reactions that rear their ugly head, and that our patient understands the medication and the treatment regimen and complies with that. Okay, implementation. So these are your nursing actions. A lot of questions come from this section. Most adrenergic blockers are given without food in general. You like to give these the same time each day. And you need to be updating the provider on how the client is responding to the medication. Is it working well for them? Are they having some serious adverse effects? Monitor the client for new or worsening arrhythmia or a change in their heart rhythm. Encourage ophthalmology appointments for clients with glaucoma. So make sure they're seeing their eye doctor. Offer comfort measures for dry mouth, like sips and chips or lozenges or gum, or maybe just like a moistened swab. And then this is a big test question. I've said it a few times now. I don't think this is on your midterm, but it's definitely one you will see again. Check the blood pressure and the heart rate before giving a beta blocker or alpha beta blocker. Very important. But also any adrenergic blocking drug, you would want to check BP and heart rate. Continue to monitor your client for orthostatic hypotension. That's low blood pressure with changing positions. And you might have to talk them through dangling at the side of the bed before they stand up, right? If giving IV propranolol, they need to be monitored. They need to be on a cardiac monitor. And then you will not, this is important, you will not give an adrenergic blocking drug if the blood pressure is below 100 millimeters of mercury systolically, or less than 60 millimeters of mercury diastolically, or their heart rate is less than 60 beats per minute. First thing you're going to do is tell the doctor. Now he or she, the doctor may adjust the parameters, but do not give the medication if it's less than 100 over 60 and 60 beats per minute. Tell the doctor first. Watch for first dose effect. Sometimes we see a pretty intense effect the first time around they get this medication. Just reassure the client that they do get used to this after a while. And then your client should not be taking hot showers, especially after taking these medications, because vasodilation happens when we have hot water running on our skin. Vasodilation will decrease our blood pressure. And then if we're taking a blood pressure medication on top, it can be very dangerous. And then with that, use fall prevention strategies and make sure your client's aware of orthostatic hypotension as a potential side effect. Evaluation, why we gave the drug, we got the right response, right? It worked like we wanted it to work. If any adverse effects appeared, we managed them or mitigated them. And then your patient understood and complied with treatment. And that is chapter 25, adrenergic blocking drugs. I'll see you in the next chapter.